Hi, can you hear me? This is Raj.
Yes,
Hello,
sir. We
sir.
can hear you.
Good morning.
Good morning.
Morning and good evening, as the case may be. John, it's good to see you.
It's always good to see you, sir. This is a better hour than the previous Echo sessions.
Yes.
Speak for yourself, John. It's 6:45 in the morning in California.
I saw that your child had been photobombing your art photos.
Yes, I'm on vacation.
Yeah, good. It's so hot in the U.S. right now, in the southern part of the U.S., that in Arizona they've canceled flights because it's plus 47 centigrade and the air is too thin to support the plane.
That we still have a minute left. You all should know that Naveen has been doing a fantastic job with creating a document on end-of-life care for the Indian Council of Medical Research. Most of the work was done by
Sir,
Naveen.
your voice is a little low for me. I don't know about others. It's not audible to me yet. Is it okay to everyone?
Yes, I can hear you.
Okay, sir. Then I'll adjust. Please continue. Naveen, let's start because now it's 7:15 and there are already 20 centers who have taken out time for us, so we don't have to make them wait. Naveen requires no introduction, so you can just start. You are starting, you're sharing the screen from your end, right?
Yes. Can you hear me? Can
Very well.
everyone hear me? Okay.
Very well.
Thank you for this opportunity and welcome to the third session on methadone. There are many experts in this group. There is Jeremy, um, there is Cashel, there is Anne. So I think everybody will pitch in, and I'm going to do a very simple presentation. It will not have much of receptors or mechanisms of action, as much as practically applicable as possible. So I will start sharing the screen, but feel free to interrupt anytime, or you can place messages in the chat board, and I will keep having a look at the messages in the chat board. So the topic goes as methadone in Indian pain and palliative care. So the Gazette of India, which was published in the year 2015, identified 6 drugs as essential narcotic drugs. Among the fourth one of them in the list, which I've highlighted in red, is methadone. The other drugs which was identified as essential narcotic drugs were codeine, fentanyl, hydrocodone, morphine, and oxycodone. But morphine, fentanyl, and now methadone is available in India. So in the year 2015, every year the Indian Pharmacopoeia comes up with a monograph, and the methadone oral solution was introduced for pain management in the Pharmacopoeia in the year 2015. And this order that came from the Central Drug Standards Control Organization in May 2016. This order was actually issued in the name of a pharmaceutical company, uh, where they had talked about using methadone for the management of chronic refractory moderate to severe pain. So it's very clearly indication has come up in the government document that's for the management of chronic refractory moderate to severe pain. And they have kept a rider actually. So they have said the drug should be prescribed by physicians trained and experienced in the management of chronic pain. I'm not sure whether any such riders were there for the earlier opioids which was prescribed, like morphine and fentanyl. I think it's prescribed by everyone. But when this order was issued by the government, they very clearly mentioned that it should be prescribed by the physicians trained and experienced in the management of chronic pain. So, is methadone a good analgesic for Indian context? So, what do we look for a good analgesic for Indian context? So, there may be many other analgesics which may be better than morphine or not better than morphine. But what we still consider morphine as the gold standard drug for India. And why we consider it as a gold standard drug? Because one, it is therapeutically effective. It has got no ceiling effect. The second thing is has got a very simple route of administration, that it can be administered orally. Optimal frequency, although morphine we have to give every 4 hourly, it may not be so optimal as we think of. Safe in organ failure. Definitely morphine is not that safe in renal impairment, especially in severe renal impairment. Cost effective. Yes, morphine is cost effective. Broad spectrum of action and presence or absence of a major life-threatening side effect, or easy to use. Now, if we look at these 8 criteria and if we compare methadone to these 8 criteria, how does methadone match up to these criteria? One, methadone is a therapeutically effective drug. It is as strong or probably more strong than morphine. And like morphine, methadone has got no ceiling effect. So we want a drug that does not have any ceiling effect. There is a trend to use buprenorphine. A lot of people are using buprenorphine. Again, buprenorphine, some of the studies are showing the buprenorphine has a ceiling effect, and some of the studies says it has got no ceiling effect. But methadone absolutely has got no ceiling effect, and it is therapeutically effective. Second, it can be given simply through the mouth. It has got 70 to 80% viability, much more than that of morphine or codeine. Morphine has got around 35 to 40% viability, and similarly codeine has almost 30 to 40% viability. So here the viability is quite good. Because of the long half-life of the drug, the methadone you may have to give only twice a day or max 3 times a day. So the frequency of administration is again much better when it compared to morphine. It is a relatively safe drug in hepatic and renal impairment, especially in renal impairment compared to most of the opioids that what we use. Methadone has got the highest safety profile. It can be used up to creatinine clearance of 10, whereas most of the morphine or codeine we cannot use in presence of renal impairment. Second, in hepatic impairment too, uh, especially in mild hepatic impairment, it can be used, but moderate to severe hepatic impairment, we have to exhibit caution. It is a cost-effective drug compared to all the analgesics if you compare, because methadone is much stronger than the morphine. It works out to be much cheaper compared to other drugs. As people have discussed in the earlier presentation, it has got a broad spectrum of action. It has got a neuropathic action because of an NMDA receptor. It has got action on the mu and kappa receptor action. It also has got an effect on serotonin reuptake at periaqueductal gray matter. So because of that, it has an action on the nociceptive and neuropathic agent. So these are all some of the positive things. However, it does have major life-threatening side effects. We all know that dextropropoxyphene went out of the market from India because of cardiac toxicity. The methadone is the first cousin, probably I can say, of dextropropoxyphene. They belong to the same group called as diphenylheptanes, and all drugs that have diphenylheptanes has got a direct action on the QT interval and can cause QT interval prolongation. So again, if if the methadone gets used indiscriminately or inappropriately, then probably we may see its exit even from the Indian scenario as the dextropropoxyphene. And next, it's not an easy drug to use. The prescribers probably had to have a complete understanding about the use of the drugs, its pharmacokinetics, pharmacodynamics, dose conversion ratios, titration ratios. So if we look at methadone in an Indian context, yes, there are a lot of good things. It's a very good therapeutically effective drug without ceiling effect, can be given orally, less frequently can be given, has got a better safety profile in renal and hepatic impairment. It's a cost-effective drug with a good spectrum of action. However, it requires a lot of training for the prescribers. One, to monitor the side effects of the drug, and also training for dose conversion and titration. So again, there are pluses and minuses. I'd like to highlight on one of the study which was published in Drug and Alcohol Dependence Journal about risk factor for methadone specific deaths in Scotland. So they studied the methadone related deaths for a period of 4 years. And one important thing what they have seen is methadone was prescribed by general practitioners who had very little training about methadone use. And second, it was predominantly prescribed in elderly population who had already a baseline QTC prolongation. So a lot of care was not taken. It was very indiscriminately used in Scotland and mainly these drugs were used not in palliative care setting, but predominantly in chronic pain setting. So this highlights about the safety that what the safety precaution that what we need to take while prescribing methadone. I heard Suresh Reddy had reassured us that methadone is a very safe drug. I fully agree that it is a very safe drug. But in an Indian scenario, what we see is the drug is more abused than used. It's the same like fentanyl patch, somebody coming and putting a 50 microgram per hour patch in a completely opioid naive person, and then developing a toxicity. So I feel that although the drug is safe, the prescriber in India may not be that safe. So we may need to take an additional precaution. Especially, I always when I talk to the pharma people, the Rusan pharma, I always tell them, please market this drug to the right people. If you indiscriminately market this drug in India, there's a very good chance that this drug could be banned soon. So when to use methadone in Indian context? In last two presentations, we have broadly looked at various indications. We have looked at conversion, titration, but in an Indian context, when can we look at using methadone in our practice? One is in patients with moderate to severe pain who are unresponsive to morphine or other strong opioids. So basically, we are looking in the setting of opioid tolerance. So if the patients are having severe pain that is unresponsive to morphine or other strong opioids, then as a second line or probably as a third line agent, we should be looking. So it should be a reserve drug rather than the first line agent that uh, first line agent use. Second thing is in presence of opioid neurotoxicity. So if patients are having intolerable side effects, neurotoxic side effects because of use of morphine or other strong opioids, then methadone would be a better choice. The third thing is in moderate to severe pain with severe renal impairment. Yes, fentanyl would be an ideal choice in presence of severe renal impairment. But if cost is a concern, then probably methadone is one of the alternative in moderate to severe renal impairment. Second, the other indication would be patients who are already having an addiction issues. We in Tata Memorial get a lot of patients from Rajasthan, and most of them patients have already marijuana addiction. So they say that okay, you give us marijuana than morphine because we have a better pain relief with marijuana. So patients who are already having an addiction issue or already have history of using recreational opioids or others, maybe methadone would be a better choice. There was a lot of debate in the last two sessions whether methadone should be used as breakthrough pain. Theoretically, it can be used because of the rapid onset of action. So by 20, max 30 minutes, the onset of action through oral route happens with methadone. But again, long half-life and other issues, the methadone used for breakthrough pain is very debatable. There are some studies which advocate methadone use both orally and sublingually for breakthrough, but I think this is not a very established indication. But I feel in Indian setting, the most important indication for using methadone is the prescriber who is prescribing methadone fully is aware about methadone pharmacology, its pharmacokinetics, pharmacodynamics, its dose titration, conversion. So then I think that should be the most important indication when to use methadone. Although we have all the above indication, if the prescriber is not having adequate knowledge or not confident about using methadone, then it may not be a good idea to start methadone. So, how to initiate methadone? As I reiterate, the prescriber should be familiar with methadone pharmacology and drug interaction. So, there are a lot of drugs that interact with methadone. Either the drugs that could cause QT interval prolongation, or the drugs that goes through the metabolic pathway. The last time Dr. Reddy has talked about the methadone metabolism and how various drugs interfere with the methadone metabolism. The second thing, sorry, I just skipped. Uh, the prescriber, when they're prescribing, should determine whether the benefits of using methadone outweighs the risk of the patient. So just because a new drug or a fancy drug has come to the market, the prescriber should be convinced and should convince the peers that methadone is the way to go in this patient, and it should clearly the prescriber and the others should be convinced that the benefits of methadone use in this patient clearly outweighs the risk. And definitely, at least you need to screen for cardiac conduction abnormalities and cardiac arrhythmias because any QT interval prolongation, either congenital or acquired or because of drug induced, could be fatal. And at least one baseline electrolytes has to be done, especially calcium and potassium. These are the two important electrolytes that needs to be done before starting methadone. So while prescribing methadone in India, again, once you are convinced, always discuss with the families and the patient about the benefits and risks of methadone, because I think they need to be aware about what benefit it could offer and what could be the potential risk. Avoid prescription of drugs that can cause QT interval prolongation. In India, we prescribe amitriptyline right and left for neuropathic pain. It can cause QT interval prolongation. There are certain drugs like haloperidol, which probably at a very higher dose could interfere with the metabolism of methadone. So again, you need to be very careful about your prescription. So look at your prescription and see whether any of this drug will interfere with methadone metabolism. And extreme care to avoid all prescription and dispensing error. We recently had a prescription error. So the methadone comes as 5 milligram per ml, and we wanted to start the patient on 2.5 milligram. That is 0.5 ml. So the 2.5 milligram, because methadone comes as a syrup, the nurse made it as 2.5 ml. So the patient received 5 times the dose of what we intend to give, because 2.5 milligram is 0.5 ml and 2.5 ml is 5 times the dose of it. So we need to exhibit extreme care to avoid all prescription and dispensing error. Now the method, once the methadone probably starts coming as tablets, these errors may be less, but especially with methadone syrups, which are currently available, it could be very dangerous. And always, like any other opioid, start low, go slow, but with methadone, more slow. Like we titrate much slower, maybe once in 2 days. If you're titrating every day or alternate day in with other opioids, you are titrating once in 3 to 4 days with methadone. So you are starting with a very smallest possible dose and going as slow as possible. And prescription adjustment should be made only by the prescriber. We have so many patients coming from faraway places. Now, I should not be prescribing something, and I should not be asking the patient general practitioner or a doctor in another city to make prescription adjustment. This could result in fatal mistakes. Actually, Dr. Suresh Reddy was talking even about the 3-day strategy for titration during the weekend, because one person starting the titration, the other person doing something else. So again, prescription adjustments has to be extremely careful and should be done by the same prescriber who is prescribing methadone. How to monitor a patient on methadone? So majority of the adverse effects of methadone are seen in the first 14 days. So usually they say that after 2 weeks, once patient does not experience any major adverse effect, usually patients tolerate the drug much better over the next few months, unless there is a change in their general condition or there is major electrolyte imbalance. So majority of adverse effects are seen the first 14 days. So patients should be very carefully monitored during this first 14 days. And second important thing is titration is not just dependent on pain, but also depends on adverse effect. Most of the opioids, we always titrate based upon the pain score. Here, you don't do the pain score, but also monitor for the adverse effects. And monitor electrolytes on a periodic basis, especially if the patient is becoming sicker, or if the patient getting dehydrated, as developing fever or sepsis, you need to monitor quite regularly. And patient's prescription should be strictly monitored. Now, you might have monitored your prescribing and you have taken all care not to prescribe any other drug that could potentially interact with methadone, but another prescriber could be starting a drug which could be interacting with methadone. So you have to monitor all the prescriptions or all the drugs the patient is receiving. ECG monitoring, there was a lot of discussion about ECG monitoring. ECG monitoring, especially the baseline ECG, is a must for all patients initiated on methadone. There is only 2 follow-up ECGs that has been recommended. That is after 2 weeks and 1 month after initiation of oral methadone. This may be practical in an outpatient setting or in hospital setting. However, I will not recommend this for a hospice setting. I don't think you should be doing ECGs after 2 weeks or 1 month after initiating oral methadone. But maybe a baseline ECG, if it's feasible, then it would be good. The aggressive ECG monitoring is only done if the methadone dose is more than 100 milligram per day, which is very, very rare circumstances that we be using such a high dose of methadone in palliative care practice. And if the patient reports dizzy spells or syncopal attacks or palpitation, which could indirectly indicate that there could be a cardiac involvement, then probably you may do an ECG. Or if the patient develops some acute medical illness, vomiting, diarrhea, or electrolyting. Otherwise, baseline ECG for all patients initiate on methadone, follow-up ECG after 2 weeks, and 1 month after initiation of oral methadone. So, what are the practical recommendations for using methadone in India? One, use it as a reserve drug. Prevent inappropriate or indiscriminate use. That's the most important thing, is to preventing inappropriate or indiscriminate use. Second, use for patients, either inpatient or outpatient, where you're able to maintain close follow-up. At least for the first 2 to 3 weeks after starting methadone, they should be accessible to you. Either they should be following up as an OPD patient, or you should be on phone, you should be contacting them. At least because the first 3 weeks is crucial when you prescribe methadone, and should be prescribed by the experts in pain management, either pain and palliative medicine professional. I think this drug should not be marketed to anybody else, anyone who do not have any training in pain and palliative medicine, because the moment the surgeons or the orthopedicians start using this drug, we had it. I'm not against surgeons or orthopedicians, but if they start using this drug, especially for post-operative pain, because this will be marketed for every indication after some time. So again, I reiterate that this drug should be prescribed by experts in pain management, and the dose of the drug to be adjusted only by the prescriber. And most important is you assess the risk before starting the drug. You do the pre-drug evaluation. You appropriately dose, titrate, document, and closely monitor the patient. I had one patient recently when we started methadone had said, "Doctor, I am not addicted. Why are you starting methadone?" So Indian patients are also aware about de-addiction properties of methadone. I think managing that social stigma is again very, very important. And I cannot reiterate enough is the safety and the safety of the drug. Just a little bit around the topic, evidence around the topic. There was a paper that was published in Supportive Care Cancer as methadone as a first-line opioid treatment for cancer pain in a developing country palliative care unit. Now, this study was done in Argentina, and this was actually a retrospective audit where methadone was used as a first-line opioid treatment in a palliative care unit. And the study population had patients with advanced cancer, had patients had moderate to severe pain, and was used in inpatient and outpatient setting. And the methadone was used as a first-line strong opioid. There were certain important findings they uh, uh, they had seen. One is the numerical. They assessed the pain using numerical rating scale, and they looked at oral morphine equivalent daily dose, opioid escalation index, adverse effects, opioid rotation, etc. And the outcomes were quite good. Actually, only 15% of patients in methadone group required opioid rotation, compared to 50% in other groups. The time taken for opioid rotation in methadone group was longer. Opioid escalation for methadone group was lowest, and oral morphine equivalent daily dose remains stable and low cost. I know a lot of us are talking about cost, but we are only talking about the direct cost. Always remember there is an indirect cost when you use methadone. We have to do an ECG, we have to do electrolytes, patient has to be monitored very closely. I think indirect costs are much higher when we are using methadone. So I think we should not bring in cost of methadone, especially in Indians when I'm talking in Indian setting. Although the actual drug cost may be low, but the indirect cost is much higher. So we had circulated a case study, and I'm very happy to discuss this case study because Sunil had asked me that we should discuss one case study where we talk about conversion and titration. So the case problem was about a 60-year-old male, metastatic non-small cell lung cancer with extensive skeletal metastasis, history of type 2 diabetes mellitus, diabetic nephropathy with a creatinine of 3 on oral morphine 40 milligram every 4 hourly, has now developed severe opioid-induced neurotoxicity. And in view of renal failure, it was decided to opioid rotate to methadone. Okay, so the question was, what would be the methadone conversion, dosing, and titration plan in this patient? So I have made it very simple, and actually I gave 4 steps so that people know what to answer. The first question was, what is the methadone conversion ratio? What is the calculated 24-hour methadone dose? What is a 24-hour methadone dose after adjusting for incomplete cross toleration during opioid rotation? And what is the 3-day strategy regime for this patient? So the answer is, now this patient is on 40 milligram every 4 hourly. That means patient is on 240 milligram. So this is the opioid dosing conversion used. I know there are different methadone dosing conversion ratio. I found a lot of people using the ratio which I've given in the slide. So I follow the same methadone dosing conversion ratio. So patient is on 40 milligram 4 hourly, so 240 milligram. So the dose conversion ratio comes in 8:1. So the methadone morphine equivalent dose is 240 milligram. So the methadone dose conversion ratio is 8:1. So the methadone dose, the 24-hour methadone dose comes to 30 milligram. Whenever we convert from one opioid to another, we decrease the opioid dose by 25%. So this is to cover incomplete cross tolerance. Some practitioners have a practice of decreasing it by 50%, but most books recommend 25% reduction in the dose. So it comes to 22.5 milligram will be the methadone dose. So if you go by the 3-day strategy method, the first day you decrease the morphine dose by 2/3 and start the 1/3 the methadone dose. So 1/3 of 22.5 is 7.5 milligram. So 1/3 of here I'm putting 120 milligram because when we convert, you have to decrease the 240 to 180. You have to decrease it by 25%. So because we are doing the conversion. So the day 1 dose will be 120 milligram of morphine and 2.5 milligram of methadone, TDS of methadone. That is 7.5 milligram per day of methadone. Day 2 is you're decreasing the 25% reduced dose of morphine. That's 25% reduced dose of 240 is 180, and 2/3 of 180 is 1/3 of 180 is 60 milligram. So it's 60 milligram morphine on day 2 and 15 milligram on day 3. And the day 3 you completely stop morphine and 7.5 milligram TDS, that is equivalent to 22.5 milligram of methadone on day 3. This is the way I convert and titrate methadone. I am sure different people have different methods of converting. I'll be open to hearing them out about this conversion or titration method. Thank you again for the uh, opportunity to present in this talk.
Thank you very much, Naveen. I invite questions on some of the specifics that he talked about, especially related to India.
Hi, Naveen. Thank you for that
Hi.
excellent presentation.
Hi.
Vijayaraghvan here. I'm in Trivandrum with Sunil and Patti. Thank you for that excellent
Hello, Vijay.
presentation. I,
Hello, Vijay.
I, I just wanted to know, is there a checklist which we can use prior to starting methadone? Or can we make a checklist?
I am not.
Just like how the airlines do. For
Yeah,
safety.
I am not. Yeah, I'm not aware. I have not seen a checklist, but I'm sure we can definitely prepare a checklist. It should not be difficult. I think that's a very good, fantastic idea. I think.
Do you mean to say protocol versus checklist?
I think protocol will give us a broad guideline about how to use the drug and how to monitor. But I think for a day-to-day practice, either to be stuck on the wall or to be part of the case file when we are prescribing methadone, a checklist would be very useful, I think.
I have a question, Naveen. There is 5 milligram per ml of methadone,
Yes.
the concentration of syrup. So suppose I want to be safe and dilute it and give it to them so that, because 1 ml is so little and 0.5
Yes.
ml is so little. So
Yes.
what can you dilute this syrup with? Either Cashel or Naveen could answer this.
We were just diluting with normal water. I don't know if there is any other diluent. Castle should be able to tell us. I think
So
I have. Yeah.
I would check with maybe Chandra Sekron about if you want to dilute it before you dispense it to the patient, what it would be most stable in there in India. But if you want to dilute it just before administration, then I think water would be fine. I don't know if you have the syrup available that it's suspended in that you could prepare in the pharmacy at a lower concentration before dispensing it.
No, it comes as a fixed concentration in marketed. I think we can just dilute with water just before dispensing. Uh, Ajit's chat, should we admit patient while initiating methadone? Answer is no, you don't have to. None of the patients whom we have initiated methadone, we have admitted the patient. But they should be either in your home care territory or within your phone follow-up, or they should be coming to your outpatients.
There are so many drugs that we use. Sorry, sir. Please go ahead. Okay, let me just continue. There are so many drugs with cardiac side effects that we use. Why do we do an ECG prior to starting methadone when we don't do this for so many others which have several complications? So, is there anything?
I think Cashel, in her first presentation, has spoke how it acts on the cardiac myocytes and how it can cause an prolongation in the cardiac conduction. There are drugs, many drugs that are used. If you look at the palliative care formulary gives a big list of drugs which we use in palliative care has an effect on QT interval. But especially when it's combined with methadone, I think probably that effect is quite exaggerated. I can show you the drugs later, or I can share the drugs which can cause QT interval prolongation. But I think that effects probably gets because that I think the same problem was with dextropropoxyphene. What we saw is the same problem that we'll face with methadone.
Dr. Rajgopal had a question. Please go ahead, sir. Sir, you're muted.
I'll quickly. I cannot hear.
So we can't hear you. Just type it on chat if you can. Naveen, you wanted to say something?
Jayarajan had posted a question. Can we initiate methadone in a home care setup? Answer is yes. If you are able to monitor the patient regularly, I think you can initiate methadone. Definitely. Will IAPC come up with guidelines on methadone? Don't know. Left to IAPC.
Anil, you wanted to ask?
Am I still inaudible or am I?
Yes,
We
sir.
can hear you. We can hear you.
Well, is it okay?
Yes, sir.
Yeah. Okay. I mean, I have a 2 or 3 points. First, Naveen, okay, I will not go into the details about dextropropoxyphene,
Yes, sir.
but over a quarter of a century, at least 100 doctors have used dextropropoxyphene very widely in their practice. We did not check the ECG. The only reports of cardiac toxicity were from recreational use or abuse of the drug. I think the main fault of dextropropoxyphene was that it was too inexpensive. Anyway, I mean, I'm not going to the details of dextropropoxyphene. It is true that we have evidence, okay, evidence from ECG against it. Anyway, particularly to Naveen, I'm going to send you an article on an Indian view about dextropropoxyphene.
Sure, sir. I'd be
My
love to.
second point is about ECG. What I mean, like at the last session, we were in two minds about ECG recommended as a routine. What would be the impact? In actual practice, the majority of patients tomorrow are going to be considered for methadone when they are at home, not necessarily in a tertiary hospital. I mean, we may need methadone in a large number of people, not as a first line, not as a second line, but if they have the patients, say 20% of our patients who get neurotoxicity with morphine, okay, 20% is not scientific. I withdraw that. A significant number of patients who get neurotoxicity with morphine. Okay, I mean, for them, we do not have any other affordable step 3 opioid in this country, which is the significance of methadone. So, Naveen, I have no experience with the medicine. Question back to you and to the group. Can we have another approach? Clinical examination, certainly looking for bradycardia. Biju's checklist, which I thought was a great idea. The checklist including a list of drugs which are usually interacting with methadone and checking for concurrent use. And then uh, uh, starting it, monitoring clinically rather than with ECG. Now, if you all people who have experience in it say that no, that's out, we cannot do that. Okay, I'll follow suit. The concept, the difference, why I am bringing this up is the difference between significant burden of reduction of burden of pain in the community and leaving them in pain. But in the interest of safety, we will have to do it if you think that ECG is a must.
My take on this subject would be that if the patients are at home care or in the hospice setting, and we feel that these patients have a very short, limited life expectancy, and we are going to continue to care for these patients at home or in hospice setting, I would certainly not recommend doing an ECG. However, if they are an ambulatory patients with a reasonably good performance status, or hospitalized patients where we feel that because of the acute illness there is a possibility of some electrolyte imbalance which could trigger. So basically what I would like to tell is if there is a preventable drug induced toxicity, I think we should try to prevent it. Especially if an ambulatory patient with a good performance status, we don't want any thing to happen to them because of the drug. Similarly, if we know that if there's a hospitalized patient and we know that acute illness could be triggering an electrolyte imbalance or could be causing acute interval prolongation, I would probably advocate you doing an ECG. However, but in a home care or in a hospice setting, the same thing would not apply. This would be my personal take on that.
Thank you. One more point, the question about IAPC.
Yes.
I think Cashel already prepared a document.
Yes.
I mean, later on, if Cashel is agreeable to this group could review it, and we could actually make it into a protocol or something. If we prepare a protocol, this group prepares the protocol. We can always submit it to IAPC. It's up to IAPC to decide whether they can accept it. But at least that much we should be able to do. This group's recommendations we can put up on our websites or wherever, and wait for the IAPC to act.
That's a great idea.
Could I?
Please go ahead.
Hi. Could I just say, yes, I think something that we've been working on sounds very similar to the checklist that people brought up. And maybe it's a good idea to have a checklist for people who are at home and more of a hospice type patient, and then a separate checklist for the patients who are ambulatory and hospitalized, just to make it more clear.
Right.
I think along with that, would be a good thing to give something as information to the patients while they are on methadone. Not only for the physician, we should make a list of things that needs to be communicated to patients when they are started on methadone. That could come along with this list. And Anne has already volunteered to share something that Iowa uses as checklist.
Just deviating from the topic, Babita had posted a question that can we reverse rotate methadone back to morphine? Yes, there is a method to reverse rotate methadone back to morphine. You use the 3DS in reverse. The only thing that you need to do is methadone has an additional NMDA receptor action. So when you reverse rotate, the recommendation is to add a drug that has got an NMDA receptor action. Otherwise, patients could experience more pain when you reverse rotate methadone to morphine. But there is again a method for reverse rotations available.
Jeremy has one question.
First of all, Naveen, thank you for another masterly presentation. It follows very nicely from the previous two. Part of me is absolutely delighted methadone is available in India now. Funnily enough, I flagged it up in the 2000 conference, which was 17 years ago, so it's taken a long time to come. But with it comes a lot of cautions, and that was the other second bit in the government edict, was the ability to only prescribe it by people who know what they're doing. I think it makes total sense to have some sort of checklist because, as Kishel said very clearly in the first one, methadone is not like morphine. It has numerous side effects. It's got the QT interval problems. It has the CYP pathways and lots of interactions. And I think having some cautionary notes before people start prescribing it makes total sense. And in terms of the conversion, yes, there are lots of different ones available at the moment. To me, it says there's no single way that's easy. And it goes back to, again, that first presentation by Kishal about the huge inter-patient variability around the protein binding, around the titration, about the stabilization. So I would just say that who's starting this, take one method and stick with it and get really comfortable with that method. Don't start chopping and changing your titration methods, because that's when you do get into problems. And some people will be stabilized within a very short time, others will take several days. And the monitoring in that phase is really, really important, because you can suddenly find somebody who's very toxic in a short while on your hands. I've been quite careful, I think, about initiating at home, unless you're monitoring very carefully. I know you've done it, and I think it's great that you have. But I think without the monitoring at home, just starting at home care is actually quite difficult. I've run into problems in the past, certainly. So I've tended to bring patients in for a day or two, or for a few days, just in that initiation and titration phase, and then stabilize them as outpatients. So I think, yes, it makes total sense to have a checklist about interactions with drugs, what to look for, because, as you said, this is a very, very different drug to morphine. And you can't just convert the practice that we all have around morphine into methadone. And certainly talking to Rusan, I think it made absolute sense that they are limiting it, is distribution to sites that are actually going to get some expertise and experience with the drug. And I think, going back to what Dr. Rajgopal said, it would make sense to have, if you like, a small group of people who are starting to get experience with the drug in India. Because the other thing that Kishal said very clearly in the first thing is the pharmacogenetics are actually quite different. And I'm very aware that even the doses I used to use in the UK with morphine is sometimes very different in India. So I think we've got to actually start getting some data around that. And if this group's an interest group, for want of a better word, I think we should actually start picking up these sort of things, particularly when things don't go well. And those are sort of flags for our benefit for the future use in the Indian context. Thank you.
I think I fully agree with certain comments Jeremy has made. I think it makes very much sense.
There's a question from Vidya Vishwanath about are there chemotherapy protocols where we need to be cautious while using methadone? This is in ambulatory oncology, and some of the chemotherapies could cause electrolyte imbalance too.
I would be a bit wary of using methadone in a patient who is on active chemotherapy, because they're very prone for either chemotherapy drug side effects or post-chemotherapy neutropenic sepsis, and I think it may be a very tricky situation to use methadone.
Just one more question. I just want to know the opinion of Naveen and others who are used to using methadone about the use of methadone in chronic non-cancer pains.
Okay. Personally, I do not have any experience in using methadone in non-cancer pain. Always my experience has been limited for cancer patients. Again, I think if it is a chronic life-limiting condition or chronic neurological disease, it should not be any different. But maybe since these patients are going to live longer, as you have written, maybe those patients may require a very structured and periodic monitoring. I think that's what. Registry of all patients on methadone, I think it's a very good idea, but I don't know how much we'll be successful with it. I think, but it's a good thing to start. I think people sharing their experiences of using it. We can ask Rusan people to have a centralized registry, because they are the sole distributors of the methadone in India. They can actually maintain the registry.
Yeah, that's an excellent idea. Then it is probably, they'll make sure it gets filled also.
Yeah.
From Rajoban, sir, like starting a methadone interest group. Establish a confidential incident monitoring program which can be shared.
Naveen, you mentioned an incident where a wrong calculation was made.
Yes, sir.
And the patient got 5 times the
Dose.
dose. I mean, there will be incidents in way of similar incidents of various types of patients. I mean, like user error or prescriber error or dispenser error. So all these are possibilities. And also the patient's idiosyncratic reactions. I mean, because we are so new in this country with methadone, maybe if we can create a safe forum for sharing this. When I say safe, I'm speaking as an anesthetist. In anesthesia, this was effectively done, particularly in Australia, where any similar incidents, just as it is done in aircraft maintenance and work, everything is reported, and that meant that a large body of people could learn from one another's incidents. I mean, from when you mentioned that incident, I mean, unless we are all aware of these possibilities, these things could keep happening. So if we can have such an interest group which is continuing to work, we will all collect a lot of data, confidential data, establishing confidentiality of the reporter and learning.
I agree with you, sir. I think that will help us to learn from each other's experience, and probably I think we may find a new incidents which we like. This is one of the incidents which I shared, but I think there may be many different kind of learnings which we can get from others.
So one question. One question: safety of using methadone in pediatric palliative care.
I have again no experience. I am strictly following the WHO guidelines when it comes to opioid use in the pediatric patients. And as per the last WHO guidelines, there is no mention of methadone in pediatric. Although it's FDA approved for use in children, in WHO guidelines, there is very little mention of methadone, and my experience in pediatric age group is very limited with methadone.
And Jeremy, anybody else with experience on it?
I don't have any experience with PEDS, but I can certainly get more information to share with the group. Cashel? Or John Ely, who's also on the call.
I'm the same as you, and I could get more info, but don't have direct experience myself.
And I can echo the same thing. In our fellowship program, we have one fellow who is just completing her pediatric palliative care fellowship, and I will see her tomorrow, and I'll ask her that question.
I've not had any with pediatrics. I've tended to be very, very cautious. But I would just go back to that question about non-malignant pain. Some time ago, I, by default really, got involved with looking after a patient with chronic pancreatitis. And his journey was a very long one, and ended up actually treating him with methadone over almost 4 years. One of the things we noticed was actually endocrine changes, which occurred, particularly around testosterone levels going right down. I'm sure other people have seen this, but the chronic non-malignant is actually, in a funny sort of way, more akin to the patients who are being treated for drug rehab, where you've actually got that chronicity. So it's almost a different setting. And the long-term effects, I think, are still being collated. And to my horror, we actually went up to, slowly escalated over many, many months, to a dose of 140 milligrams a day. which was absolutely, to me, quite horrifying, and absolutely horrifying to the GP. But that was the only thing that actually kept on top of his pain. And when we tried to rotate him back to other opioids, it was a complete dismal failure. It seemed to be the methadone was the only thing that helped his very, very nasty pain from the pancreatitis. But that's a one-off, and I suppose we've all got anecdotal stories, but there's a learning point in all of them about long-term use. So I'm sure the others have got similar experiences.
Symptoms a patient would have developing cardiac toxicity due to methadone so that they can contact us when in home care?
This is the most important cardiac toxicity. Mostly it manifests as palpitations and feeling dizzy, frequent syncopal attacks. These are the very early signs of cardiac involvement of methadone before they probably have a frank cardiac arrhythmia. So I don't think we may have many warning signs, but it could mimic as any cardiac arrhythmia, either like a mostly syncope or a palpitation probably.
So the nurse, when doing, or a physician, when doing a home visit, in terms of physical exam, could check for bradycardia, irregular pulse, etc., as just some baseline general findings that might raise a conversation. It is true, as Dr. Naveen just said, that sometimes it's a catastrophic arrhythmia. But any of the kinds of physical symptoms or any changes in physical exams could at least start a conversation about what do we need to do for reassessment here.
I would
Sorry.
I would also add that a patient who's having nausea and vomiting might be more prone to have potassium or magnesium abnormalities, and so that might add a risk profile. I think it's startling to me to think about an arrhythmia starting as a bradyarrhythmia, that is, low heart rate is more of a risk than a fast heart rate. So think about Torsade as a bradyarrhythmia. I think is very helpful. So bradycardia, nausea, and vomiting would be what I would have the home care nurses look for, or be looking for myself at home care.
Answering Rajit's question, we do not have parenteral methadone in India, although I had used earlier. I think if the patient can take methadone syrup, and if you want to give methadone, that would be the way to go. Injectable methadone is not available.
I had a question. If a patient shows signs of developing some issue at home, like dizziness, syncope, how do you proceed? How do you handle such a patient with the dose of opioid, as well as will you transfer such a patient to IP, or just reduce the dose and continue monitoring?
Yeah, it would be probably very hard to clear-cut pinpoint and say this is methadone related, or it could be just the disease related progressive illness. I would feel that okay, if you really suspect it's methadone, to stop methadone and skip the dose, although it is going to have a longer half-life, so it's going to take time to clear from the body if it's methadone related thing. However, I would not think about shifting and trying to reverse the dose. I think we are all going to titrate it well and use it very carefully. So it could be unlikely a dose related thing unless we have done a mistake.
Thank you.
Where else do we get methadone? I think it's many places in India we are getting methadone. I had recently been to Hyderabad and they are using methadone already in Hyderabad. So I'm sure in Delhi and other places it must be available. I'm not sure. What about Mayank? Do you know in Delhi?
I'm not working in Delhi right now, sir, but it's not available in Uttarakhand. I think so. Megha or Gaurav would be better to answer that.
It's not available, I think, in Delhi. We don't have that.
Anywhere in Kerala, I don't know. Sir should tell us. Is it available anywhere in Kerala?
Naveen and others in Kerala, only morphine is currently given to RMIs. I mean, it is all decided, but regarding implementation of the NDPS rules of 2015, we are still waiting for a government order that is just to satisfy the various government departments who have to accept this. So only when the order comes, we'll be able to procure it. Till then, the drug controller has asked us to hold on.
I think we have completed the time, but John, please go ahead with your comment. We'll take that. It would be so useful to this group.
Two quick comments. I think it's going to be an interesting journey for nurses and physicians to evaluate things like a person feeling weak, a person feeling dizzy, a person feeling dizzy to the point where they need to sit down when they're at home on methadone. On one hand, we need to take these things very seriously, and the other aspect of that is that people who have chronic illness, people who are frail, people who are have a lot of debility may commonly feel weakness, may commonly feel the need to sit down. Maybe their orthostatic blood pressure has changed as they stand up. So it'll be an interesting process to sort through those issues of how do we detect cardiac abnormalities. Another thing that crossed my mind is because people do have these things, these symptoms not related to methadone, one might consider when is it, if we see symptoms like this, when is it possible to do an EKG? When is it feasible? When is it meaningful to do an EKG to see if there's been the change in the QT as you decide what to do? My quick final comment is that Dr. Naveen had spoken earlier about somebody saying to him, well, that methadone, that's for addicts. There is that stigma for some people, and there, I think in India there will be different awareness. Whenever I start a patient on methadone, one of the things that I also do is ask them and their family, have you heard of this drug before? And if people have heard of it in a negative context or in a different context in terms of management of addiction, that gives me a chance to say, you know, you're right, it is used in that setting, but it's also used by cancer pain specialists such as myself, such as yourselves. So that open question, have you heard of this drug before, has sometimes given me good information. So that's all my comments. Thank you.
Thank you very much, John.
So valuable. Thank you so much. So, friends, we come to the end of this such a filled with learning lesson. Is this session, and let's meet again on 27th